Welcome, everyone. Thank you for joining me for this GAP MASLD Community Network event. I am Lavinia Iordache. I am a physician assistant with 10 years of experience in outpatient and inpatient hepatology, and I am affiliated with University of Miami. Thank you for joining me today for this presentation. We are here to discuss the nuances of steatotic liver disease, with a focus on key differences between MASLD and MetALD. And since we are talking about the nomenclature, I thought I would be starting with this slide as the first slide. So we know about the nomenclature change from NAFLD and NASH to MASLD and MASH, which occurred in June 2023. After a multinational consensus. Sorry, just went too further, I guess. Okay. And SLD was chosen as the overarching term to encompass various etiologies of steatotic liver disease, amongst which we find alcohol-associated liver disease, or ALD, as well as the MetALD entity, which refers to patients with underlying MASLD who consume greater amounts of alcohol, which, as we can see here, can range from 140 to 350 grams per week for women and 210 to 420 grams per week for men. Or we can take a look at the weekly ranges of 20 to 50 or 30 to 60 grams daily, respectively. Just a quick note on this slide on other causes of steatotic liver disease, such as viral C, hepatitis, malnutrition, celiac disease, monogenic diseases, think Wilson's, lysosomal acid lipase deficiency, or cryptogenic causes. So we will go over a case, and our patient, let's call her Ashley, is a 52-year-old woman who is being evaluated by a specialist due to evidence of increased hepatic echogenicity and hepatomegaly on ultrasound. She feels well without any complaints. So in that case, you might wonder why she had an ultrasound in the first place. And it turns out that her liver enzymes were mildly elevated. And as we can see here, AST 55, ALT 40, alkaline phosphatase 140, a little bit out of the range, total bilirubin 1.2, which is borderline. We also know that she has an abnormal BMI of 29.4, elevated triglycerides, 185, and elevated hemoglobin A1C, 5.9%, which would place her in the pre-diabetes range. And her vitals are normal. So indeed, our patient has a history of hyperlipidemia as well as hypertension, and she's on atorvastatin and amlodipine, respectively. But what stands out in her social history is her daily alcohol intake, reported at approximately 2 glasses of wine with dinner. So she not only has cardiometabolic features, placing her at risk for MASLD, metabolic-associated steatotic liver disease, but also has risk factors for MetALD. So let's do the math. We have here the typical serving size and alcohol content of standard American drinks. For wine, we can see that a standard glass of wine of 5 ounces contains more or less 12 grams of alcohol. This is from Rethinking Drinking website, which is listed here. And I think it can really put into perspective alcohol consumption if we share it with our patients. So in regards to Ashley, I believe this chart looks familiar now. And the question is, where does she fall into the spectrum? So based on the numbers we have seen, we can assume she consumes approximately 24 grams of alcohol per day, or 168 grams of alcohol per week. And here is where her numbers line up. So number one, she does fall into MetALD category. And number two, MASLD is the predominant feature. Sorry, I went too fast there. So she is more towards the MASLD spectrum of disease. So her evaluation would include a FibroScan. And here are the results. Control attenuation parameter was 310, consistent with severe grade 3 out of 3 steatosis. And the median liver stiffness was 11.4 kilopascals, which is suggestive of F3 significant fibrosis. So having significant fibrosis is, of course, worrisome to us and to our patients. And thus, these are the instances when we definitely must act quickly, have the risk factor conversation, try to identify disease promoters so that we can focus on minimizing risks and aim towards prevention of cirrhosis and hopefully achieve hepatic regeneration. So for our patient and many others, MASLD and alcohol intake coexist and are the leading causes of steatosis. The two share histological and pathophysiological features, and together they lead to more advanced disease by activating multiple inflammatory and fibrogenic signals. There is a beautiful article by Diaz et al. Published in August 2023, which highlights the intersection between alcohol-related liver disease and non-alcoholic fatty liver disease. And this was presented in Nature Reviews on Gastroenterology and Hepatology. So we know that patients with concurrent risk factors are susceptible to faster progression of disease. The metabolic risk factors are listed here on the left, and our patient has quite a few of them, including insulin resistance, poor diet and lifestyle choices, visceral fat. We should also take into account the added risk for potential genetic susceptibility. Therefore, family history can reveal important information. We also know, and is illustrated here, that dysbiosis or disruption in gut microbiome can trigger inflammation in the gut, which can spread to the liver through the gut-liver axis, causing hepatic steatosis. Dysbiosis also affects how the body processes fats and sugars, and so impacting liver health. And alcohol is a known disruptor of the gut microbiome, thus leading to liver disease through yet another pathway. The take-home point is that hepatic injury occurs through multiple mechanisms, and current evidence indicates that even low levels of alcohol can exacerbate liver injury in susceptible individuals with metabolic syndrome. And so at the moment, there are no available data to recommend a safe level of alcohol consumption in patients with MASLD. So drivers of liver disease. This is another way of visualizing the distinct but intertwining etiologies of steatotic liver disease, starting with metabolic factors, genetic predisposition. And we can see here how added alcohol use leads to higher risk of decompensation, especially in the patient population with advanced fibrosis. How do we detect alcohol? Of course, history is irreplaceable, but we must also consider the possibility of underreporting of alcohol use due to fear of being stigmatized. Enter detection of alcohol with biomarkers. We have here listed a few metabolic factors here on the left. And before we talk about the frequent alcohol testing that we use in our practices, a quick note on a few other methods that were used in a study comprising 184 patients for whom alcohol detection was assessed by measuring ethyl glucuronide in the hair and the urine, listed here as H-ETG and U-ETG. The results were compared to the alcohol use disorders, identification test, consumption or audit C, also to MCV, GGT, and the ANI index, which can distinguish between alcoholic and non-alcoholic fatty liver disease. And they also looked at SCR, which is skin conductance response, a physiological measure that can be used to assess the impact of alcohol on the body. And to be precise, SCR is decreased in patients with AUD, with alcohol use disorder. So the conclusion they reached was that 28.6% of patients with NAFLD, so patients with evidence of steatosis on imaging without any other risk factors, and 25% of patients with MASLD, patients with at least one marker of metabolic syndrome, were at risk of alcohol-related liver damage. In other words, we need to make use of all the tests at our disposal to identify high-risk patients and take the appropriate steps, starting with counseling. So the gaps in the assessment of MetALD. This chart is somewhat familiar. It essentially illustrates once again the SLD classification, starting with the risks and features required for a MASLD diagnosis here on the left. But this chart actually emphasizes the differences between MetALD and ALD. Needless to say how important it is to be diligent about obtaining a good social history. So we have to consider asking several key questions, starting with the type of alcohol preferred, because as we saw, the alcohol content is different in each one, but also delving a bit into the drinking patterns and inquiring about potential socioeconomic consequences. All of these things can give a ton of information and guide expectations for achieving abstinence from alcohol. We talked about the limits of alcohol use for MetALD, namely 140 to 350 grams per week for women and 210 to 420 grams per week for men. So anything exceeding these numbers would classify under alcohol-associated liver disease or ALD. Now, introducing PEth testing, which is common in clinical practice and has proven useful in identifying high-risk patients. A PEth value over 200 is associated with ALD. PEth is also useful in proving alcohol abstinence for those unfortunate patients who have progressed to decompensated liver disease and are now being considered for liver transplantation. So a PEth less than 20 suggests low or no consumption. A value over 200 is consistent with excessive alcohol use, and anything in between is suggestive of moderate alcohol use. And as we can see here, this is where our patient Ashley falls into with a PEth of 120. So the first graph here on the left explains how much more valuable PEth testing is in comparison with ethanol testing, which is what is usually being performed in emergency rooms. As we can see here, the blood alcohol level so the BAC tends to increase exponentially in the first 2 hours, but drop significantly at 8 hours and may even go undetected after as little as 12 hours, while PEth steadily increases in the first 8 hours and is detectable up to 12 days or even longer. And here on the right, we can see that there was no variability in PEth detection by sex or BMI. Therefore, PEth is a much more useful test to do as opposed to the regular ethanol testing. Now we will focus on the relation between alcohol consumption and individual features of metabolic syndrome. And we will go over the data from a few studies which aimed to expose the causality between alcohol use and liver damage in patients with underlying MASLD. So this slide is to illustrate the results of a study performed by Diaz et al. In May 2025, aimed at using NITs, non-invasive tests, such as FIB4 or transient elastography, or stratifying fibrosis in patients with MetALD. They screened a lot of patients, as we can see. In the end, due to inclusion-exclusion criteria, much less were actually enrolled. They were patients with a history of overweight and alcohol use, either self-reported within MetALD range or a PEth greater than or equal to 25. And they concluded that 15.7% of the patients with overweight were at risk for MetALD. So this was actually the San Diego liver study. It was a cross-sectional single-center study. And while there were some limitations, for example, they mentioned FIB4 having a lower specificity in patients over 65 years old, lower sensitivity in patients with obesity. But overall, the study concluded that their patient sample was well characterized, and their findings supported the current guidelines for MASLD and MetALD populations. And they came up with this chart, which we all know, and we use it to stratify patients with high risk for advanced liver disease. And we hope that our colleagues in primary care and endocrinology use it as well to guide the referral process. The expectation and the hope is that patients with a median liver stiffness of 8 kilopascals or greater should be evaluated by a specialist, as they may be candidates for treatment. And in addition, they may need closer monitoring, including screening for hepatocellular carcinoma. The reality is that liver disease is complex, and many times there are competing etiologies, and therefore it is important to establish pathways for appropriate screening, which would hopefully facilitate early diagnosis so that timely interventions can be applied. Going back to the patient's comorbidities, we note that in addition to an elevated BMI, she also has a history of high blood pressure and hyperlipidemia. So we will talk about the relation between alcohol and these two diagnoses. It turns out alcohol has a biphasic effect on blood pressure. Initially decreases the blood pressure, only to lead to a spike after 13 hours of consumption, which is not ideal, of course. There is also an interesting relation between alcohol consumption and triglycerides levels. The blue line refers to patients with alcohol intake, yellow line evident for patients with administered water. Circle lines illustrate patients with baseline high triglycerides, while the squares pertain to patients with normal lipid panel. And it seems that in patients with high triglycerides, alcohol alone is not an acute lipemic agent. As seen here, upon alcohol consumption, there was only a minor increase in triglycerides in patients that already had elevated triglycerides levels. But there was a striking lipemic effect in patients with normal lipid panel at baseline, who experienced a 53% increase at 6-hour follow-up. So this would support the idea that excessive alcohol should be avoided even by, quote, healthy patients without obvious underlying comorbidities. And this is important because many times the conversation that ensues in clinic is somehow geared towards obtaining sort of an approval for continued alcohol intake, as patients say, in low doses. But as we can see, alcohol can actually trigger features of metabolic syndrome in addition to worsening them. So this slide is a summary of our journey today and our presentation. So our patient Ashley falls under the MetALD spectrum of steatotic liver disease with a predominantly metabolic etiology for which she has several underlying risk factors. And to all of this, the alcohol has contributed, leading to a faster progression of fibrosis. So at age 52, she already has grade 3 steatosis and F3 fibrosis illustrated by FibroScan. So what do we have to offer Ashley? Are there any treatments available? So this is a beautiful topic for another in-depth presentation, but in a nutshell, in addition to recommendations for lifestyle changes, including Mediterranean diet, weight loss of 5 to 10% of body weight, strength and aerobic exercise, we now have the opportunity to offer a pharmacological treatment to our patients with advanced fibrosis since the FDA approval of Resmetirom in March of 2024. This partial thyroid hormone receptor beta agonist stimulates lipophagy and inhibits lipogenesis and was designed to target and improve liver fibrosis and steatosis. Our patient is a candidate for Rezdiffra given that she has stage 3 fibrosis, so she would probably be treated with that. In regards to alcohol use, we advised complete cessation in order to minimize the risk for further progression to cirrhosis. And a very important question listed here, does she need screening for hepatocellular carcinoma? And the answer is absolutely. Monitoring for HCC is extremely important in our MASLD population, as MASLD accounts for about 35% of cases of HCC worldwide. And research shows that 15 to 46% of patients with MASLD-related HCC do not actually have cirrhosis. And also important to mention that cross-sectional imaging is preferred in patients with central obesity, as ultrasound can potentially miss up to 41% of HCCs due to an incomplete evaluation of the liver parenchyma in the setting of a thick subcutaneous adipose layer. So ideal MetALD definition for clinical trials, we want to make use of biomarkers to overcome underreporting and certify abstinence from alcohol. We would want to evaluate for cardiometabolic factors and also evaluate to see if they persist or resolve after alcohol cessation. And consider exposure to other risk factors within the last 6 to 12 months. All right, so the final take-home messages today. Quantification of alcohol intake will help us appropriately classify our patients under the correct spectrum of steatotic liver disease. So namely a range of 140 to 350 and 210 to 420 grams of alcohol per week for women and men respectively, in addition to the presence of metabolic factors. Both are required to make a diagnosis of MetALD. We need to insist on the patterns of alcohol intake, in addition to using biomarkers such as PEth routinely in our clinic. And we need to reassess the metabolic dysfunction over time to ensure that it is still present after alcohol cessation, and determine if the features of metabolic syndrome were otherwise induced by alcohol, as we have seen in the studies that the alcohol can influence the blood pressure, the triglycerides level, and so on. And for future research, we would encourage studies to observe alcohol-related liver disease and MetALD in different sociocultural populations. So with that, I'd like to thank you for your attention. I hope this was helpful, interesting, and I'm happy to answer any questions if there are any. And otherwise, I wish everyone a great day. Thank you for listening.